Well, all right. Well, good evening, everybody. I think we're all excited to host this, now what I believe is our third Super Bowl of debates. This was a wonderful idea of Tim's. We were kind of in the throes of COVID, and really, I think, brought a lot of energy to the webinars that we were putting on at that point. And it's really been one of the kind of most well-attended and most anticipated webinars that we do every year. It's kind of become its own annual event. It's really fun to see all the engagement and interest in this, and having over 1,000 people registered for this webinar today really speaks to what our members really like to see. We have really a kind of jam-packed agenda today, but it's going to be hard-hitting and quick, and I think very insightful. We have really great sponsors that have supported this, not only with the resources to put on this for free for everyone across the globe, but also to kind of help us really kind of think through some of the therapies that have gone on to be used in our patients over the last several years, and then bringing world-renowned experts on these topics to really speak to what really are the pros and cons of a lot of these treatments. With that, I'll kick it back to Tim.
Well, thanks, Dalwood, and I'm so happy everyone's with us tonight. You have those colleagues out there who tell you their opinion, either on LinkedIn or in your clinic or when you go to a meeting, and they're so certain they're right. A lot of times they are right and they're evidence-based, but many times they're wrong. And you don't really have a chance to have a discussion without someone really maybe overpowering you or saying they're right and going about their business. Tonight, we have some experts in every area of the 8 debates. They're going to give you their reasoning from evidence-based thought process of why a certain treatment may be correct for your patients. And someone will have a different opinion of that. And then the moderator will try to come together at the last moments of each debate, which will be very fast and hard hitting, and give you really a question or two to ponder for the debatants to discuss, and I think that's gonna be very important. So Dalwood, I'm very excited about this. Thanks to our sponsors, thanks to our debatants, and thanks to everyone, again, about 1,200 people who's with us tonight and many more later online, because these are the types of things we learn from is each other. And I want everybody to humble themselves tonight and be willing to accept different opinions. It may be different than yours, and maybe you'll change your mind tonight. Dalwood, back to you for the lineup.
Yeah, absolutely. So again, the lineup here is, again, you can kind of see it here, and I think maybe we can advance the slide and kind of see the back half of the program as well. So again, really a nice mix of neuromodulation and minimally invasive spine to kind of really kind of highlight the evening. And to go through kind of the format of today, just some disclaimers. Again, this is a non-CME industry kind of sponsored type of program today, so that you're going to hear a lot of expert opinions, and so everyone has kind of their viewpoints. This is a lot different than when you come to our annual meeting where everything's a CME compliant type thing. So you will hear some things here that potentially are more expert opinion than basic science type, evidence-based, dogma. But I think that's what makes this a really interesting format, that we can really have these open dialogues. I think the folks that we have brought on here are really well respected, and they will still, keep things, in a way that I think is meaningful and thoughtful. So the format is going to be, there's a pro and a con to each one of these topics. The pro will go first. They will have 2 to 3 minutes to frame their argument. This will then be rebutted by the con. The con will also have 2 to 3 minutes to also frame their counterpoint. Each debater will then have about 60 seconds to respond to their opposing opponent. And then at the end, if time is permitting, they will get a question from the moderators at that point. So with that, let's kick it into the first debate, which is myself and Dr. Chakravarthy.
So here we are. I think I'm going to ask Dr. James to introduce herself and really ask the first question of the debate.
Hi, everyone. Thank you so much for joining us this evening. Thank you to Dr. Deer and Dr. Syed. And my name is Whitney James. I'm a neurosurgery trained minimally invasive spine surgeon in Arizona. And we're going to kick off tonight with a debate on anterior column low back pain. Why not start with basivertebral nerve ablation every time? And I was originally asked to argue the con, and I couldn't think of good reasons. So I said I didn't want to do that. And so thankfully, Dawood stepped in and is going to argue the con, which I'm really curious to hear his argument. So let's get started with Dr. Chakravarthy.
All right, thank you. So, Dawood and I are probably prepping another important matchup between the Bills and the Chiefs. And so every year the Bills have a slogan, squish the fish. So this year it's going to be squish the Chiefs. So I'm going to get started and I'm going to prove to you guys why it's so important when you're thinking about, as a steward to this specialty, I have seen in the last 3 to 5 years, even 7 years, all of this wonderful new therapies that come. And part of that is that it's really important when you are looking at these new therapies and you're integrating it into your practice, there are certain tenets of what you would think are important when you're trying to triage these patients and putting something first line versus second line. And I break that down into several important things. One, is there an evidence that's basic science and clinical that supports what the clinical data says? So when you think about vertebrogenic pain, really there is no other therapy currently out there. And really the mechanism behind that is this underlying hypothesis that a lot of mechanical, nociceptive, mixed signal back pain really does originate at the vertebral end plates. So when you're thinking about that target from both a scientific and clinically rational way, you really want to have the evidence of that being a target that supports good clinical data. So when you think about randomized controlled trials, we've done 2 big 5-year RCTs comparing it to sham as well as traditional conservative therapy, really showing good durable outcomes. And 5 years is really a testament to making good selection in therapies that are going to be long lasting. The next thing is really once you've got the clinical validation, you've got the proof of concept, good clinical research, does the actual evidence hold up in the real world setting? And so today we're probably about 20,000 patients in that have been treated by BVN, and the consistency of that outcome, and we all recognize that individual providers based on technique, based on differences are going to certainly have suggested differences. But the point is that when you look at those real world outcomes, they need to support the randomized controlled trial data. That's really the importance of why we give something a level of evidence. So, when you think about that and you think about the backing of all these different societies really saying that BVN is a great frontline therapy and first line therapy for vertebrogenic pain, it's really hard to argue why it shouldn't be. And I think we're at a time where in our specialty, we're in a shortage of good comparator data. And part of that is we got to use the level of evidence and the graded evidence that we have to make good clinical decisions. So before I turn it over to my esteemed colleague, I want to quote his paper, which was written by Syed et al., which actually places the BVN as a level A grade evidence for vertebrogenic pain. So, I think we're really fortunate to have these amazing folks that support these wonderful therapies. So I'll turn it over to the esteemed Dr. Syed.
Dr. Syed, your rebuttal.
Yeah, so I think Dr. Chakravarthy made some excellent points and quoting, and to start off, obviously, I'm a big fan of this treatment. We led a best practice guideline supporting it. But, this question here is why not start with basivertebral nerve ablation every time for anterior low column back pain? And I have a big problem with that. I think, this debate, the Bills the Chiefs took care of the Bills in 12 seconds a couple of years ago, and I have 2.5 minutes now to completely shred Krishnan, so it should be pretty easy work. So, again, really, because you can't do it every time. If you look at the studies, they didn't do BVN ablation on every patient. You have to look at what the inclusion exclusion criteria was. So BVN ablation is really only indicated for L3 and below. They have to have modic type 1 or type 2 changes. So again, if a patient has no modic type 1 or modic type 2 changes but has anterior column pain, the evidence suggests that you should not be doing BVN ablation for those patients. And again, I think there's this whole kind of thing we'll hear about later on in the Viadis, topic. How do you distinguish discogenic pain from vertebrogenic pain? Now, I think we know that our radiographic colleagues, our radiologists have helped us with things like modic grading, but then also you look at the Furman grading system. Again, these are things maybe earlier than when you see, modic type change. When you think about someone with a mid-Furman grade, modified Furman grade of 4 or below, would you do a BVN ablation on them? I think the evidence would tell you not to do that. There's probably going to be better treatment options for those patients down the road, such as an intradiscal therapy. And then last but not least, our surgical colleague would probably really kind of think of us as not very good interventionalists, or even our surgeon colleagues that do that, if we were doing this on every patient. Let's not forget about instability of the spine. If you have anterior column pain and you have a high-grade spondylolisthesis, there's no way you can convince me that BVN ablation is the right answer for that patient. So again, I think my final thoughts are that BVN ablation is a great therapy for people with L3 and below anterior column pain with modic changes. But all these other things you have to take into account. Can be pain coming from the anterior column, but if you do it on all those other patient populations, I think we'll fall into the same trap that we have with certain things that I think are great therapies. Take, for instance, interspinous spaces for moderate spinal stenosis. I think the evidence suggests that it's actually a really good therapy for that. Why that therapy sometimes gets kind of looked down upon is because of these using it for everyone with spinal stenosis, severe spinal stenosis with instability. So I think we cannot get into that same trap with this therapy. And those are my closing thoughts.
Krishnan, you have 1 minute to rebut that, and then we'll get to the final minute. Then Dr. James will tell us who won the debate.
No, so I think that the point here is that nobody is suggesting that people adopt a therapy without a good history, physical, and imaging evidence for a specific type of therapy. Now, we understand that there is a certain, if you really break it down to the sensitivities of, should I look at modic 1, type 2 changes? Is forward flexion to posterior extension distinguished between anterior column versus posterior column? I think the point is, if you do a good history physical and you corroborate that with good imaging findings, then as a clinician who's looking at using good evidence-based therapies, there's very little out there as strong as basovertebral nerve ablation for anterior column pain. It isn't discounting that there are probably candidates that may not be a good candidate for this specific therapy. I think the challenge is that there are so many patients that are untreated, primarily because I think our space is confounded by so many different therapies without a rigorous diagnostic set to try to actually diagnose that. So let me give you a good example. If you look at vertebral disc or interdisc types of treatments, one could argue, is it any better than saline? A lot of the evidence is really based on what, and you look at the level of evidence, the grading, that's partially why I think it's really important to use that level of evidence and really use a diagnostic history, physical, and imaging to really fine tune when you're using that therapy in that patient set.
You get a penalty for illegal motion for going over your minute. Dawood, last thoughts, and then Dr. James and I'll discuss your thoughts.
Yeah, I mean, I think Krishnan again brings up some really good points, and I think I'll still quote, or go to the fact that again, why this is not the best treatment for everyone is because there's so many variables when you think about this. When these patients show up into our clinic, it's axial back pain, and let's just go all the way back to the Dennis Columns and Dr. Dennis, who kind of looked at spinal injuries and talked about the anterior, middle, and posterior columns. You really have to figure out where it's coming from. And sometimes it's very hard to distinguish anterior column pain from middle column pain, because again, part of that posterior complex of the disc is part of the middle column. And how do you figure that out? I think we know that BVN ablation probably works for isolated anterior column pain. Some of these patients have mixed pain. If they have axial back pain, I can tell you when I see a patient with modic type changes, a lot of them also have set hypertrophic changes as well. So what are you going to do in those patients? Again, I think everyone has to work through what their algorithm is. I think usually it's going to be part of, a real world kind of thing. What can you get approved for that patient and what's easier to do?
Dr. James, you get to summarize this debate and really tell us who won this series of this first debate.
Okay, great. Well, you both did wonderfully. Great job. I'm going to give it to Dr. Syed for winning the debate. I thought his argument was stronger, especially with the dynamic instability. So if the patient has more than 3 millimeters motion on flexion extension, lateral x-rays in the lumbar spine, you want to be thinking fusion, not just BVN. However, I think if Dr. Chakravarthy had said, you should do the BVN every time, L3 down to L5S1, in patients with modic changes, no dynamic instability, and no other obvious sign of axial back pain with pain on flexion. I think that would have won the debate as well. So great job.
So the winners, Dr. Sad, on this debate, now on the debate too. Thank you, gentlemen.
Thanks, Chris. Thanks, Whitney.
All right, thanks, guys.
All right, debate number 2.
All right, so debate number 2, another really kind of interesting topic that's, I think is kind of something that we looked at in the past, but we're looking at it now, I think, with newer instrumentation and hardware and techniques that are, not even minimally invasive. I almost consider these new techniques to do these procedures almost ultra minimally invasive. So we're going to talk about facet joint fusion. Dr. James is going to be moderating with me, and our 2 debaters are Tim Deere and Leo Caparo, who really don't need any type of introduction. So Dr. Deere, you lead it with the pro.
Yes, sir. We'll have 3 minutes. I'm honored to be here with Leo tonight, a dear friend of mine. Leo, I will say that, I think John F. Kennedy in 1961 said we're going to go to the moon. And a lot of people were doubting that. They were skeptical. And then, as you know, Neil Armstrong lands on the moon a few years later. And I think the same thing is true here. A guy named Matt Ranson was a doctor with me. He's in Arizona now. And he did some facet fusions about 8 years ago in my practice. And they all failed. And I was a skeptic. But now I think we're going to see a real need for this because facet joint disease is so common. Grade 1 spondylolisthesis is very common, particularly at L4-5. And really, we have people who don't do well long-term with ablation. A lot of people do, and that's wonderful, but not everyone does. So if ablation works well, and then you're one of the world experts in ablation, I think it's a great solution. But in those who don't, I think facet stabilization is a great option if we do it correctly. And I think Dawood hit on it in his introduction. And so the unmet need is really ability to stabilize it. And really some new work we're doing really shows that really we can actually focus on the facet and go in and do something very minimal, Dawood, and you've done some yourself, but the lacking things lately and things that have been out there has been no safety stop. So there has to be a safety stop so you can't go through the joint. And there has to be more stability so you can't pull that out, because in the past, these products were often unstable with movement. So I think we're getting there. I think new materials have made that possible. And I think that what we'll find is we'll have an algorithm, Leo. I think you and I'll probably agree on this. They treat it conservatively. They have facet ablation. If that's successful, it's wonderful. But in those patients who are unsuccessful with that ablation, or it doesn't last 6, 12, 18 months, I think we need a long-term solution. I think it's going to be cost-effective for everyone. And again, today I did 5 minimally invasive surgeries this afternoon, things we're doing very similar to this. I think it's the same set of skills. And I think the skill sets we already have in our interventional practices, our neurosurgical practices. And this is the next evolution, the next thing that's coming in the area of minimally invasive spine. So that's my pro. I don't really have a con towards Leo, as he knows of what I'm saying. But the next steps to make it safer, more stable, more efficacious, and more efficient. And I think we can do some large surgery sparing, but also I think neurosurgeons may use this along with other anterior methods where you use combined techniques. I think that would be the other appropriate use of this therapy. So it won't be just interventional spine, neuroradiology, interventional pain. It'll also be our neurosurgical colleagues. So that's my pro discussion, and I'll give it over to Dr. Capro.
Leo, what do you have to say about this? Tim is using the F word, which is kind of the bad word, fusion, for facet joint. So what do you think about this?
We don't want to fuse everything, do we? No, I actually am not against the longevity of the pain relief in selected group of the patients. But I'm not against the fusion, but I'm pro something that is bread and butter in our everyday practice. And this is optimization of radiofrequency ablation that we haven't achieved yet, despite the fact that we've been using it for 20, 30 years. Evidence mounted, especially recently. Just look at this issue of Pain Medicine Journal, and you'll find this beautiful anatomical study from University of Toronto, same group responsible for geniculate, shoulder, and hip. Beautiful anatomical studies suggesting that more parallel placement than we ever did before would probably provide much longer relief when it comes to radiofrequency ablation. We are pain physicians. We want to help with the pain long-term with these patients. our study also suggested when we exchanged 22 gauge, 20 gauge, 18, 16 gauge, and cold RF electrodes, that we were able to consistently provide longer relief of the pain. So we are not there yet. What we thought was quite parallel placement with this inferior pillar view and inferior angle with a 10 degrees or 15 degrees oblique, it's not even close to that angle that they were showing in this study. That's number one. Number two, how about those patients who already have relatively fixed spine, advanced degenerative disc disease? So you're going to fuse them in the back and basically limit their motion completely. Keep in mind, facet joints are those in lots of anatomical studies, especially recent ones, documenting movement that it's not only extension and partial flexion, but also lateral flexion with extension. So really 360 joint that enhances our ability to mobilize. Now, in some patients that preserve anterior structures, that will be fantastic because you won't limit them too much. But those who have advanced disease, that may be a major problem. So those are some of my arguments.
Really good arguments, Leo. Tim, you care to respond or fortify your argument?
Oh, absolutely. I think Leo made some terrible points there. So let me just correct a few of them. We're talking about fusion one level usually in most people and not multiple levels. So the mobility is pretty well maintained. I think also, we're talking about a really low risk procedure if done correctly in the proper hands. So I think both those are important. I think that everyone listening tonight knows a lot of people fell medial branch blocks. And this 80% pain reduction, temporarily twice is really hard for patients to achieve, and I think it's really hard. And so what are you gonna do with those people who fell those medial branch blocks? They'll never get to ablation. And insurance companies are making it harder and harder to get to ablation. And then it has to be sustained for at least 6 months at 50% pain reduction now. A lot of people have multiple comorbidities, and so they don't get that 50% reduction for 6 months or more. So there's a lot of people out there who Leo would love to do RF on, and I know the articles he quoted are good articles, but unfortunately, they either fell the medial branch block or they failed to get 50% relief for 6 months or more, and now they're stuck and they have no options right now. So I do think what we're talking about is giving them an option that could change their life, and we're talking about one level in most patients, not multi-level.
Definitely, I would love to see evidence in randomized prospective study on a facet fusion, and I would definitely be happy to endorse it over long-term period, especially because of the overlapping pain from other sources in the back.
All right, well, it looks like we have our debate at its conclusion. Dr. James, I'm going to give you the honors and the pressure to anoint a winner again.
So this was a tough one. A question from the audience was, what guides you to use, what guides do you use for osteoporosis and facet fusion? And in my experience, a patient with osteoporosis or severe facet arthropathy can have very frail and friable facet joints. So if you go to fuse the joint with one of these devices, the facet can just break off. The superior inferior facet can just break off, and then you're in a pickle. So something that's really important to consider. For the debate, I'm going to give it to Dr. Caporal. He won me over with the, why do patients still have posterior column facet joint pain when they're auto fused in the facet joints? And I do see that quite a bit, and it's a good question to answer. So congratulations to you both. This was a hard one.
All right, there we go. Debate 2 is over. Dawood, on to debate 3. Thank you.
All right, let's go to debate 3. So now we're going to shift gears here a little bit from minimally invasive spine and go into neuromodulation, specifically peripheral nerve stimulation. We're going to have Dr. Mogum and Dr. Vali Muhammad talking about the dynamic landscape of interventional pain and understanding kind of the differences between temporary and permanent therapy for peripheral chronic pain management. And with that, we'll let Dr. Mogum take the floor with his pro-permanent argument.
Thank you, Dr. Saeed. I appreciate that. I'm going to frame this from a perspective of kind of where our specialty is headed. And really, it's an era of disruption is occurring. Where I started looking at peripheral nerve stimulation to incorporate in the practice was really to lower dependencies on these temporary treatment options that we have abundance of. We're used to repeat epidurals. We're used to repeat RFAs. And what that ends up doing is setting a landscape for restrictions over time. I mean, you cannot separate the cost of a therapy with its viability. Viability has been proven over and over again on therapies that are lower cost relative to other therapies and those that typically fall under more permanent solutions. So my list for incorporating a therapy now does not just include whether it's just minimally invasive, does it work? It also includes, is it permanent? And will it hold up within the context of our medical system, which is where I really want to hone in. We know we have plenty of studies out there. In fact, the American Society of Pain and Neurosciences, this society here has produced a great evidence-based clinical guidelines, last year, August of 2022, that pretty much shows that peripheral nerve stimulation does work. Now, why would I advocate for something that's permanent over temporary? Is because that's where this field is headed. We already have plenty of temporary options. So if you're going to be placing temporary leads, and now you have to remove them 60 days later, the patient's pain returns. What do you have to do then? You have to repeat it, okay? If you repeat it, that's now a repeat procedure. We have plenty of those. And the whole industry is moving away from that. We are restricted almost every year, and we know this through epidurals, right? Insurance companies, Medicare is watching all of this. And every year they come out and they restrict these temporary therapies. What other arena is similar to that? Well, that's chiropractic care, right? Why isn't chiropractic care covered? It's not covered because it's temporary care, right? We'd send them to chiropractors to rule out, hey, this doesn't work, so you can come back and get surgical care. So the way I look at it is we don't want to go backwards. We need solutions that are permanent, and we have to pay attention to the cost, or else it's not going to be viable long term. So what good is it to have a therapy that we cannot utilize for our patients if it becomes more and more restrictive, just like we've seen with a lot of our other temporary options. That's essentially my point. Now, if you want to use a temporary, I think there's a place for everything. If you want to use temporary approach, you use it once, and if it fails, then you must go to permanent. That's going to save our field, allow this therapy to continue on for us.
Bobby, great kickoff to the debate. I think you made some really great points. Ali, you're up for the con side of that.
All right. Well, thanks guys for having me. Thanks, Aspen, and thanks my colleague here for his presentation. I think it's amazing where we've evolved, right? Part of the reason PNS failed in the past was the technology couldn't keep up with the actual therapy itself. And now look where we're at, right? We have multiple systems and multiple options to choose from. And more importantly, right, we're choosing devices which are made for the periphery, right? They have stretchy leads, tines, microstimulation that are actually designed for where they're placed. And I clearly think there's a place for permanent implanted systems, and I myself utilize them on a regular basis. However, I would contend that starting with a 60-day or temporary PNS treatment instead of conventional trial should be first line. And this is better for patients and payers who we're ultimately responsible to. And I'll tell you why. So, a temporary device can have potential for long-term results, which would obviate the need for a permanent implant. And, since we brought up pricing here, this is desirable to payers, right? This means lower costs in terms of no IPG, no revisions, no IPG replacements, many of which we see costs for, as well as explants. And from a patient perspective, right, this device is, these temporary devices are less invasive in terms of their micro leads. They're smaller, they're going through a needle, do not require surgical incisions, which, ultimately leads to, lower infection rates. And so because the device is smaller, it can stay in for 60 days, right? And because it can stay in for 60 days, it allows for treatment temporarily, which hopefully is therapeutic, But it's more importantly, there's some data that was released by Nadeau and some of his colleagues, which showed that there is a proportion of patients which are identified that we often miss. So up to 30% of patients can be delayed responders. So what this means is a conventional trial in 7 to 10 days is not going to capture these patients who ultimately would have done very well with regards to stimulation. So you're missing a large portion of patients who could have done well from the therapy overall. They just need more time, right? PNS and SCS are not the same, and clearly we kind of see that in the different MOAs and waveforms that we're using. And so I think this opens up the therapy to many more patients. At the same point, there are a large portion of patients who are delayed non-responders, meaning they responded well during that initial 7-day trial, but afterwards they don't respond. And so that's your explant data, right? And again, that leads to cost, money, unnecessary surgeries, patient dissatisfaction, and ultimately more headaches for us as well. So I think that's very important. But most importantly, the data is there. There's 30+ peer-reviewed publications for this. In the real-world studies, which were just recently published this past year by Huntoon in 2023, showed that in 6,000 patients, right, 71% of those patients were responders, meaning 50% pain relief or more, with sustained relief, with improvements in functional mobility too. So, while I do think there is a place for this, I think Sprint should be first line to give our patients, the best options and to avoid complications as well as to keep costs low.
Well, really strong argument, Ali. So, Robert, what's your response to this? Should a 60-day trial be the new gold standard prior to a permanent implant?
No, I don't think so. Because in my experience, most of my patients actually utilize the therapy. So if you just looked on my last LinkedIn post, I have a patient that's 4 years out, peripheral neuropathy in the feet. She utilizes it when the pain returns. That is majority of these patients. So I'm not necessarily seeing the same in terms of in real life in our practice. And we primarily, again, our philosophy is always going to be go toward more permanent solution. And again, there's no adverse difference between adverse events. I'm not removing these at a huge clip. And I think overall, you're going to find that it's going to be way more beneficial to payers to say, hey, look, I do this one time. They have this therapy in. If the pain returns, I don't have to go back and do it again. So if you're doing this over and over again over the period of 2-3 years or even 6 to whatever the time span is, I just don't think it's going to hold up.
Ali, you have 60 seconds to rebut that, and then Dawood's going to pick the winner of this debate.
Okay. Well, I mean, I think there's SCS data that kind of shows, unfortunately, over time, the cost can be quite high. And so that's why, I think you picked a good point to kind of hone in here. And I think there's a unique place for both of these therapies. Again, I would just argue that this should maybe be first line, given the fact that we can identify more patients who may respond long-term, right, ultimately to help them. And as you said, right, there'll be a place. Should they have failure of therapy to respond, I think a permanent device could come into play. So I think, again, looking at the data, which shows good long-term response, if I were personally able to have one of these, right, I'd want the one that would be the least invasive and reversible. And if it needed to come back, I would go with the one that, that had a permanent solution, in which case I think there are a few solutions out there. I think it's just about finding the right spot for each of these. Again, just looking currently at the data out there, for me, in my practice, this is kind of what I kind of see the landscape looking like.
Dawood.
Well, I think, both of our esteemed colleagues and physicians made really strong arguments. I think I liked Ali's thoughts about, really not losing much by doing this front line. But I think Robert's going to have to get the win here because, I think we're talking about chronic pain management. And I really think that his argument that, the downside of putting this in and a lot of this pain returns, and we want to be good stewards of the therapy, I think I'm going to have to give a slight edge to Dr. Mogum with the win.
All right, there you have it. Debate 3 is over in the books. Thank you, gentlemen. Next debate, Dawood.
All right, so now we're going into the mild procedure. So percutaneous or minimally invasive lumbar decompression. This is a procedure now that's been around for quite some time now that, the procedure has been kind of changed and modified, from how we did it when the original studies came out. And additionally, there's other things that we talk about now where when we look at some of the complex spinal stenosis patients and doing this in a multi-level setting versus, having the patient come back and doing one level at a time. So I think that's really going to be the bigger focus of this debate. And I'm going to have Dr. Dickerson kind of kick us off.
Yeah, Dave, let me frame this for a second, if I could. So I do something called the streamline approach. Dr. Kim, my partner, we've been together over 25 years, does what I would call the kind of mainstream old style approach. So who's right there? Let's hear your pro side on the streamline approach.
So I think if we expand on our understanding of going streamline, which is single incision to treat patients, reduce fluoroscopy times, and as well as to access multiple levels in both sides to that single incision. The next phase of streamline is perhaps to think about streamlining the optimization of the entire procedure. So in streamlining that patient's journey to the positive outcome that we should see with this procedure. The focus we're going to really look at also is, should we be staging these procedures, as Dawood mentioned, or should we be doing them one and done? And what is the real upside to each of those approaches? So in terms of thinking about a streamlined, multi-level approach to getting the work done, I really think about three things: patients, payers, and politics. So when I think about the patient part of this, we have an efficacious procedure established in 2 randomized control trials with 2-year outcome data, the MOTION study and the preceding MIDAS ENCORE study. And if you look at that treatment cohort, the patients that were treated in those studies have the indicated levels treated. And yes, the majority of them had single level procedures performed in both of those studies. But patients who needed 2 levels treated were treated at 2 levels in that study. So if I want to talk to patients about what they can expect, and my APPs are talking to those patients, and those patients are going to come back and see those APPs after I do my good job, and I'm going to use those studies as a crux for what those patients can expect, I should effectively be following a similar behavior. So that's that patient's first patient component of this. And it also really feeds into how my practice gets to do with this. When we think about payers, we really have to think about the idea of CMS has this procedure still enrolled in a CED. And to go back and do another mild procedure on a patient who had a mild effectively registers as a failure. Additionally, we get to fail if we do one level, see the patient back and think, you know what, I should have treated that other level. Well, guess what? Because of that global, we're going to probably be waiting a year before we can bring that patient back. Heaven forbid I only did one side and I want to go do the other side because they still have symptoms that look consistent with that single level disease. So that's a whole nother staging I wouldn't do. And then there's the PainTEQ. And along that PainTEQ, we really want to preserve or steward, which is I think the hot word of tonight, steward this therapy appropriately so that what we know the data shows is what we see in the real world. And so as we steward that and we avoid the politics in this competitive landscape of who should we be doing what, getting the right therapy for the right patient at the right time comes back to also doing it the right way, which I would say is really to make sure that you treat the indicated levels in a single trip to the operating room. And yes, use that streamlined approach that you can do many levels with less fluoro and be able to replicate the great data that we see with that 75, 80% response rate in the MIDAS ENCORE and MOTION studies.
Aaron, you're up. Your thoughts?
Yeah, well, it's really hard to disagree with Dave on this. I think there are 3 things that we can briefly look at, and that is staging this procedure. And there's no way I can argue that it's good to stage this procedure. I can't think of really any reason to deliberately stage it, except for some very unusual circumstance where a patient could not be prone for more than a few moments so that you could only do a level at a time. But otherwise, this procedure is still under CED coverage with evidence development. And also, every time you bill this, you bill it with an NCT identifier. That's a national clinical trial identifier. So Medicare still considers this to be under a clinical trial, and all that data is scrutinized. So I agree with David. If you bring a patient back having failed a half one level or a 1 level procedure and you bring them back, it looks like a failure. Not a good idea. But when you talk about single versus multiple levels, I do think there's an argument to be made to do a single level. If you look at the ENCORE study, which we were a site for, nearly 70% of those patients were treated at a single level. If you look at the MOTION study, which Dr. Deere was first author of, nearly 60% of those patients were treated only at a single level, and only 10% of those patients were treated on a single side. And then if you look at Nagy's 5-year retrospective study, 75% of those patients were treated at a single level, and about 10 to 12% were treated at a single side. So single level procedures, I think, are the norm, not the exception to the norm, although it is hard to pick the proper single level if multiple levels are abnormal, because as we know, there's very little correlation between the severity of the radiographic findings and the severity of the symptoms in spinal stenosis. And also, it's very difficult to tell on physical examination, except if patients have, say, upper leg anterior thigh pain, what level might be involved based upon physical exam findings or symptoms rather than radiographic findings. Now, if we expand the discussion to talk about classic versus streamlined, I'd like to suggest the possibility of a hybrid approach. I think the need for an epidurogram has been debunked. I don't think it's necessary. In fact, I think sometimes when I do an epidurogram, the contrast might even obscure my ability to visualize what I really want to see. And I tend to make more than one stab incision because it allows me to use a very optimal angle of approach at levels, even if I'm doing a level above an instrumented fusion.
Great points. Dr. Dickerson, you have 1 minute to respond.
So I really think that we're both honing in on answering a question that we want to answer for to win our side. We're both sort of pivoting towards, well, I heard single level or multi-level versus single levels discussion and staging. But what we're both talking about, whether it's streamline or classic, it's all about right sizing the treatment on the day of surgery for that patient based on their anatomy, their exam, and our best understanding, and then also the access we get. And I love that last point you made about being still willing to use the classic approach to achieve that core tenet of getting the patient the right treatment when you take them to the operating room. Optimizing the outcome comes down to optimizing that technique. So I'm going to have to agree with you on that. I think that's great. Save room for classic when necessary if your angles don't look great and you're not getting ligament back. So I'm going to give you that point. But what I will say is when we come back to 1 level versus 2 levels, so many of our patients in the real world have these multi-level diseases when they present. And I'm always more likely to go ahead and treat that moderate level if it's there because I have them in the OR.
Yeah, I can't disagree with that. But overall, I want to make sure everybody leaves with the understanding that this procedure has a significant amount of evidence base to support it. 2 RCTs, including Encore, 2-year data that's excellent, and including the motion study. Again, Dr. Deer's first author on that. And then 5-year data from Nagy McHale. It's a really good procedure, and the complication rate is exceptionally low. So whether you choose to do single level or multi-level, whether you choose to do a classic versus a streamline, I think that's between you and the patient. The results are outstanding if you do the procedure properly.
So there was a bank robber named Willie Sutton, you may know about, and they said, Willie, why do you rob banks? And he said, that's where the money is. So I think this debate's going to go to Dave because, you treat the problem where the problem is. And many times, and Aaron, you pointed out great data, many times it's at multiple levels. And when it is, you should do that. When it's 1 level, you should do 1 level. But, I think you have to go where the money is and do what's right. I think also you have to do the ligament before you do something metal above it. So if I'm going to do something like posterior lateral orthodesis, you gotta do mild first to open that up so you can get there with something else. So great debate, gentlemen. I think you both are winners, but I'm giving Dave the victory in this debate overall.
Great job, gentlemen. Thank you so much.
And now our next debate, diabetic peripheral neuropathy. We know that the FDA has approved this indication now for neuromodulation, and we have one of our first authors, the president of ASPN, on one of those papers, and she's going to argue the pro side for the next 3 minutes. So, Dr. Peterson.
Hi, everybody. Thank you very much, Tim. Thank you, Dawood, for having me, and thank you to all the attendees as well. Painful diabetic neuropathy is a growing problem in the US. There's 5.7 million patients who have refractory diabetic neuropathy who need something of help. What we know is that in the past, conventional medical management and pharmacological treatment has not made a significant impact. People, about 70% of people who start pregabalin will discontinue it within a year. And so we have a real problem with efficacy, and that's what led to a renewed interest in using non-pharmacological treatment, particularly spinal cord stimulation, to address painful neuropathy. I was really honored to lead the largest study in spinal cord stimulation to look at painful diabetic neuropathy, and we've published now 24-month results showing a durability of response. 90% of patients studied were responders at 24 months with at least a 50% reduction in their pain. 65% of those were profound responders with at least an 80% reduction in pain. The most important thing, and why 10 kilohertz spinal cord stimulation has been highlighted by both the American Diabetic Association in their clinical compendia, as well as by the American Association for Clinical Endocrinology as the preferred waveform, is because of the strength of the data compared to other waveforms that have been published in the literature. We put a review in the journal Pain Research earlier this year in August with me and other authors. There are 15 studies which had significant populations looking at painful diabetic neuropathy. The strongest of those outcomes is with 10 kilohertz, both looking at durability as well as the strength of the evidence. And I'd encourage people to refer to that study to get a full discussion of all the options, including not just high frequency stimulation. What I think is most important and what really highlights things is twofold, not just the pain results, but actually what we've been able to demonstrate in terms of holistic results. What we see is not just improvements in pain, as I already cited, but also quality of life. We saw a 66% improvement in sleep disruption, which was also maintained at 24 months. We saw neurological improvements, and this is one of the first studies that actually looked at and quantitated neurological improvements over time, with 66% of patients demonstrating at 24 months an improvement in neurological function. That is really key because this doesn't cure diabetes. This is something where you would expect people with diabetic neuropathy to have progressive neurological loss, and yet they had stable to improved neurological function at 66% of people at 24 months. What that translates to ultimately is a reversal of the loss of protective sensation problem. And if you can stop people from having foot injury, foot ulcerations, damage and wounds that lead to amputation, you actually improve morbidity and mortality for diabetes overall. And also we've been able to demonstrate changes in terms of A1C as well as weight loss, and 11.9 pound weight loss in people with BMI over 35 shown at 24 months. So there's a lot more beyond just a VAS score improvement that's been demonstrated in 10 kilohertz, which right now makes it probably the most robust, comprehensive, holistically impacting disease state managing and changing therapy option for patients who are looking at something to address not just PD and pain, but diabetic neuropathy and diabetes overall. So until we have stronger evidence for other waveforms in other areas, I would suggest that right now the strength of evidence is in these publications, and that's why ADA and AACE have both endorsed 10 kilohertz specifically as the waveform as an option.
Really strong points, President Peterson. Dr. Pope is not available right now, so Dr. Deere is going to take his crack at the con on this.
You know, I didn't prepare for this, Erica, but I think I've been preparing for it my whole life. You know, Drew Bledsoe was the quarterback of the Patriots, and he got injured, and some 6th-round draft pick came in named Tom Brady and took over. So I'm hoping I can go along that route. I will say there's 4 companies approved for neuromodulation for diabetic peripheral neuropathy. There's a reason for that. You know, the reason is, and you pointed out quite well, only 6% of patients have good 50% reduction of pain and tolerable side effects long-term with medication. So there's a need, there's an unmet clinical need for neuromodulation, whatever company you prefer to do, and you've got great data on your high frequency data. So, but I will say the other thing I want fellows and residents to learn tonight, we know that high sugar, you know, uncontrolled diabetes affects your retina. We know it affects your kidney. We know it affects your heart. But I think what most people don't realize is you can have diabetic peripheral neuropathy and have very well controlled sugar. You can be pre-diabetic, you know. So if you learn one thing from this debate, and again, you know, again, Dr. Pope's on injured reserve tonight, so I'm taking over without preparing to face this great competitor. But I will tell you that when you see someone with pain in their feet, they're on metformin or any drug like that, in most settings, that will get you to approval for neuromodulation. Why is that? Because the data is good. We have good data. You know, we have good data in recent studies that Dr. Peterson pointed out, and in older studies. You know, we have a lot of studies where diabetic neuropathy patients are mixed into real world data. So it's a great therapy. There's also papers that Dr. Pope and Dr. Fulowski produced on DRG for peripheral neuropathy. So you can kind of use what you feel is best for your patient. And I don't really care what you pick, but you pick something that's going to have a good chance of a good outcome, that you're familiar with, that you have good representative coverage for. I think lastly, I'm going to be hopefully in the next few months working with Darren Wilson, Sean Puri down in Texas. We're going to be working on it, and some other folks. We're going to be working on a guideline for ischemic pain. Why is that important here? A lot of these diabetics also have ischemic pain. When we think about that, we're going to be able to treat people that have comorbidities that cause foot pain, whether it be neuropathy, ischemia, or other issues, and that will lead to better wound healing. It'll lead to better function. It'll lead to better life quality. It'll lead to less amputation. So I do think we have diabetic peripheral neuropathy and stimulation. We have ischemic pain and stimulation, which we have to prove, and we're gonna hopefully have some great studies out there. And we already have some data out of Germany and other places that are quite good. And they're going to be a mixture of those patients that you're going to see in your practice, and you're going to help those patients. You help them a lot more than they're getting with high dose, oral medications like gabapentin and Cymbalta, where they're often having neurological, mental complications, and many of them are older and already confused. So that's my my 3 minutes, Starwood. I'm conceding this debate to Dr. Peterson because I thought you did a wonderful job. And next time I'm preparing for you, Erica, so be ready. But I think it's a great discussion. So back to you, Erica, for your 1 minute rebuttal to that.
Well, Dr. Deere, thank you very much. I'll have to agree with you that any stimulator is better than no stimulator in these patients. And even when you look at the HFX device, you remember that not everybody who has a Nevro implanted HFX device uses 10 kilohertz, because there is the opportunity for 2 hertz all the way up to 10 kilohertz with all the different paradigms that they choose to offer. So there's a lot of flexibility, and there's a lot of opportunity to continue to work here. One of the things that I'm most excited and interested here is that what we're seeing with a lot of these changes that I mentioned holistically in the picture of improving a patient is that there are real opportunities at looking at non-pain indications for spinal cord stimulation. I love that you brought up ischemia here. The next great frontier for us is to figure out where we can intervene with spinal cord stimulation and neuromodulation outside the brain in a way that affects non-pain problems that our patients have. And so that's an area we need to go forward with.
So for my last minute, I do prefer other waveforms to HF10 in most of these cases. And I do think that you should use what's best in your practice. So whatever that may be, I think that's what you should use, whatever you have the best outcomes for. But I do think that you should choose it based on following your own outcomes and how your patients do. So if you're having great outcomes right now with whatever you're using, I think that's a great opportunity to continue that. If you're not, I think you need to look at what other options are out there. And that's what this discussion's been about. So, pick what's best for your patients currently, but also keep your mind open, because there may be other therapies that are out there in the data that look quite good, and you may have even a better outcome. So let's just be open-minded to what may be best, whatever that could be, and treat these diabetic neuropathy patients, and I think you'll be really, really favorably pleased with how they do, and they'll be very thankful. You do have some diabetic, last thing I'll point out, my last 10 seconds, Starwood, you have some patients who don't feel anything or when you even map them, and that's okay. They don't really need to feel this for it to be helpful. A lot of them can't really perceive any type of paresthesia when you map them, but that really shouldn't really discourage you. They still may have a great trial and go into a great implant. Darwood, back to you.
Well, I think, really strong points on both ends. And I think, Tim, this is kind of akin to, Drew Bledsoe going down and Tom Brady stepping up and winning the Super Bowl. Since you are very gentlemanly conceded, I'm going to crown you both winners, but there is one clear loser, and that's Dr. Pope and his Northern California network bandwidth issues. So hopefully he'll be on with the next one for us. So thank you, Erica.
All right, thank you very much. Next debate. I think this is a great debate, you know, and that's about SI joint dysfunction. It's a problem we all see very commonly. We used to ignore that, Dr. Hen. We used to ignore that all the time. And you're going to be the first pro speaker in this debate about algorithms and clinical evidence. Do they matter? So with that, Dr. Hen.
Thank you very much. I appreciate it, Tim, and thank you, Dawood. I'm going to do some slides, if I may. So I'm a neurosurgeon based out of Fort Myers, Florida. These are my disclosures. I believe that evidence matters. I think that's the key to being a responsible physician. I'm extremely risk averse and I hate complications more than just about anybody. So how do we do what's best for our patients and minimize complications? And the answer is use evidence and base your decisions on evidence. If you don't have evidence, accept that you don't know and basically get the evidence you need to get. Why can't we just rely on experience? Well, because our decisions can be fraught with errors. We have sample bias, observer bias, confirmation bias. We also have what are called heuristic traps. One of my patients unfortunately said to me, I've lived in Fort Myers for 35 years and never died in a hurricane. That was before the last hurricane and that did not end well. So we obviously rely on the scientific method. We need evidence to make our decisions. What happens if we don't have evidence or we ignore the evidence we do have? That's not a rhetorical question. We have thalidomide, we have cigarettes. Probably just about everybody on this talk tonight in some regard was affected by the OxyContin crisis and the pain control with minimal risk of addiction, lack of evidence concept. So there are two companies in the SI fusion space that have evidence, SI-BONE and PainTEQ. SI-BONE, of course, was the original to the field. They do the lateral technique. They did the heavy lifting and prove that SI fusion is effective, durable, and much better than conservative. Unfortunately, their evidence also showed there are risks of doing a lateral approach. PainTEQ, on the other hand, has done the lion's share of the work in the posterior space. They have evidence showing that they're biomechanically as good or better than SI-BONE, comparable clinical outcomes, and much lower risk of complications. So I would argue the new standard. So this was a biomechanical study basically comparing posterior to the lateral technique and remarkably showing that the posterior approach was as strong or stronger based on the ligamento-taxis. This was a clinical study done by PainTEQ, a single-arm multi-center prospective study. Over on the right side, you can see the results. Secure was the PainTEQ study compared to the lateral approach. And basically, you see similar results in VAS and ODI over 1 year. Bottom line, that's evidence that it works. The key difference is complications. The lateral approach has a lot of complications as shown in the database, and these are real complications, deaths, hemorrhages, nerve injuries, the kind of things nobody wants to think about, much less in the posterior approach. And that's based on the approach. In the lower left, you see the blue arrow is the relatively safe approach of the posterior technique. The red arrow is showing the lateral approach. You're basically bringing into place your passing arteries, so you have risk of bleeding. You're heading towards nerves, so you have risk of nerve injury, et cetera. So clearly posterior safer than lateral. So are all the posterior systems as safe and clinically effective as PainTEQ? And the answer is without evidence, we don't know. On the left, we have PainTEQ. We have cortical bone with demineralized bone matrix. And the important thing is preserving the cortex of the SI joint. It provides the structure. In the middle, we have a couple competing systems where they intentionally destroy the cortex and we worry about subsidence. Over to the right, we have both a hybrid system, which again, without evidence now brings in the risk of lateral again. And lower right, you have a new system by Nevro. It's a metal cage that has these razor blades that extend out into the bone. Again, may or may not be a good idea. We just don't know. They have 2 years of data unpublished that says biomechanically that cage is as strong as the little screws they showed there. But again, we don't know what that really means and they haven't published it anyway. So what if I do have a complication? Well, you manage it, you fix it. If you need help, get help, communicate. If your decision was based on solid evidence, then that's just part of life. We all have complications and that's part of doing any kind of a procedure. Does not mean something was done wrong. However, if there's no published evidence to support your decision or the device, that's much harder to defend, much harder to sleep at night, and much harder to defend legally. But the rep said their product is safe, or just like the other system, the bottom line, you're the provider, you're the physician, the patient trusts you to make the best decision or the best recommendation. And if a company has not invested the time and money, which is significant, to obtain the evidence, you have to really question, can you trust their product and can you trust that company? So this was advice given to me when I was a medical student. The secret to being a great doctor is to know what you know and know what you don't know. After that, everything else becomes clear. bottom line, that's Confucius, Richard Foltz, and that's evidence. That's all. Thank you.
Really nicely done, Dr. Hen. Dr. Przybylakowski, you're going to take the pro experience counterpoint to Dr. Hen's argument.
Great. Thank you, Dawood. Thank you, Tim. Thank you, Aspen, for having me tonight. So, you know, it's great. Jeff kind of has done a lot of the explanation for me already. I mean, we know that allograft works. PainTEQ's leading the field in terms of generating evidence for allograft. The question I have to the people out there is, you know, what makes one allograft from one company different than another company? In my opinion, there really is no difference between the different products on the market, right? So we know that allograft works. PainTEQ's leading away with that. I've fortunately worked with a company that's been evidence-based over the last 6 years with Nevro, which now added a new product into their portfolio. And you'll see within the next 2 years, we're gonna, two to 3 years, we're gonna lead the way in generating evidence for their new metallic implant. So the first thing I do when it comes to explaining what we can do to fix this problem for patients is I outline the risks and benefits of a general anesthetic with a hospital stay, with a lateral approach, with a typical product like SI bone versus a minimally invasive approach, 15 to 20 minutes outpatient procedure. And most of my patients choose a minimally invasive approach. So really I'm outlining that, you know, using allograft or this posterior approach, we know it's safer. Jeff already outlined why it's safer. There's less risk of any neurovascular damage when we're using these types of products into the posterior aspect of the sacroiliac joint. It's an outpatient procedure. It takes 15 to 20 minutes for most of the companies we're using with allograft right now. There's minimal pain post-procedure. The risk of harm in terms of hitting a superior gluteal artery or going into a neuroframe is minimal when we're using a posterior approach. And you're really not burning any bridges. So the first thing I think about when I'm doing any procedure, I agree with Jeff. Number one is it's safe, because if I do something that's not safe, can I reverse the untoward effect, right? So I'm not confident. I don't want to be doing lateral fusions. I don't know how to do a lateral fusion. I don't want to start doing lateral fusions. I understand the posterior aspect of the joint space very well. I reread Dawood's book this past weekend. He goes over all the techniques to treat the SI joint, whether it's lateral approaches, SI joint RFA, SI joint PRP, SI joint injections. And we know the posterior approach to this space is safe. And when you're trained as an interventional pain specialist, like I was at the University of Pennsylvania, everyone is trained on a posterior approach to the joint space. The nice thing that's going on right now, we now have a category 1 code with CPT 1 code 27278 that's now reimbursed for a posterior approach into the joint space to fuse the joint, whether it's with allograft or with a metallic implant. Besides, you know, wanting to help the patient and give more durable benefit, the other thing I want to know is, am I burning any bridges with my neurosurgical colleagues? Because these are the guys referring me a lot of patients for neuromodulation, epidurals, facet blocks, what have you. I'm not burning any bridges when I do allograft posteriorly. These patients can still go on to get a lateral fusion with an orthopedic or neurospine surgeon. It remains to be seen, because I agree with Jeff, we need to generate the evidence regarding metallic fusion from a posterior approach before at least I feel confident marketing it to my patient population. So the nice thing is most of these patients are already sitting in our practices. Most of the spine surgeons I deal with don't want to deal with them after they've done an L5 to S1 or L4 to L5 S1 fusion. They're sitting in my practice. They have low axial back pain. It's over the buttock. I do an SI injection. They get relief. The relief is temporarily. They say, what can we do next? As of January 1st, just a week ago, we now have a CPT-1 category 1 code 27278, reimburses very well at the surgery center. It's safe. It's a posterior approach to the space. This is a big win for us in the interventional spine field. This is a big patient population. It's a book of business that's worth close to $3 billion. And, you know, we are just at the infancy of treating the SI joint from a posterior approach as interventional spine doctors.
So Pete, very nice work. Jeff, you have 1 minute to discuss Pete's comments, and particularly his comment about a new device.
Well, overall, I thought what Pete said was right on track. Obviously, it sounds like we agree more than we disagree, which that's a challenge for us. Obviously, I know it's supposed to be a debate, but it sounds like-minded people think alike. We both agree that anything you can do that's in the patient's best interest and is safe. It sounds like, and I did not talk about the fact that you're right. Before you get evidence, You have to do something, and you do your best until you get the evidence. So just because some company doesn't have evidence doesn't necessarily mean it's a bad idea. It just means we don't know yet, and you have to accept that. You have to probably also counsel your patients that newer technique, and we're not exactly sure how this is going to turn out. I think the only other caveat I would throw into the mix is revision. Revision of any kind can be difficult. Revision of SI fusions is extremely challenging. Going in to get the thing out that was relatively easy to put in can be very challenging. It's one of the reasons that I have in the spine, I use a lot of metal, but in the SI space, I have to admit, I feel very comfortable with the allograft, because God forbid you put it into the sacrum or into the ilium, or you get an infection. Almost in every single one of those cases, you could treat that supportively. You don't actually have to take anything out. I'm concerned about a metal implant that would have to be removed, whether it's a screw or device, just because, again, that would be hard for me to do, and I do a lot of crazy surgeries. So at that point, you'd have to at least invoke getting one of your orthopedic colleagues involved, presumably. So,
Peter, 1 minute response.
Yeah, just in rebuttal to that. So the company that acquired Vertos Spine created the largest randomized clinical trial in the history of neuromodulation. Got a new FDA approval for neuromodulation when we hadn't had a new indication for that product in over 40 years. I'm confident that a company that's based on evidence is going to generate that evidence in the next 2 years. The product itself that they'd acquired is reversible. The metal tines that go out into the sacrum and ilium, you can screw back into the device, deploy the tines back into the metallic insert, and remove it. So that had to be cleared prior to FDA approval. So those are things I've done in the biomechanical lab to show it's reversible.
So Dawood, you've heard a great discussion here. It's time for you to pick the winner.
Yeah, I think, both of our panelists today made really strong arguments. I think Peter really kind of set the stage for new technology, and kind of how us as, interventionalists and kind of being on the leading edge sometimes do have to take a leap of faith with things that we really believe in and use our experience. But I think at the end, evidence wins. I think, with the compelling arguments on evidence and showing safety and efficacy, I'm going to have to give the win to Dr. Hen on this one. But it was a close one. Good job, gentlemen.
I'm happy to share it. I think Peter made some excellent points, and if I had been put in the opposite position, I think it would have gone the other way. So
I thought you both were awesome. Good job, Pete. Good job, Jeff. Wonderful work, both of you. Thank you so much.
Yeah.
All right, we're on to back to, as we get through this series of debates, we have a few more to go.
Yes, I think, this is getting funner as the night goes on. So our next will be sponsored by VIVEX, ViDisc. So we're going to be talking about the degenerated disc. Is it restoration, not regeneration? We'll start with the pro with Noman Azim.
Noman.
Look like a Tampa Bay Bucks jersey on.
That's right. Thank you, Tim, and thank you, Dawood. Thank you, Aspen, for giving us the opportunity tonight. So earlier tonight, we've already discussed a few different options for low back pain. And why is that? Low back pain is the leading diagnosis of all clinical conditions combined. That includes cancer, cardiovascular disease, and diabetes. It's the first and top causes of a year's lived with disability. Lumbar disc degeneration itself is regarded as one of the major contributors to chronic low back pain. In fact, in some literature, it's cited to contribute more than 40% of all chronic low back pain. But beyond low back pain itself, what else are we looking at? The degenerative disc, a lot of times, is the catalyst for the spinal degenerative cascade. So that includes instability, facet arthropathy, spinal stenosis, things that have been brought up tonight with a lot of the other therapies. If the anterior column pain is confirmed with history, physical exam, and then the MRI reveals modified Furman grading that's consistent with discogenic pain, then we really need to go down the pathway of treating the discs. The current treatment algorithms include conservative treatment like physical therapy, chiropractic care, acupuncture, and then a little bit more invasive with injections, and then we get into surgical options and a lot of open tissue disruptive surgeries, the most recent option being artificial disc replacements. So how can ViDisc help? Well, ViDisc is just an acellular nucleus pulposus homologous allograft. It consists of proteoglycans that will assist the disc in rehydrating. And what that does is it restores the function of the disc, which then leads to improvement in pain, but quality of life. And also it impacts that disease progression of that degenerative cascade that I discussed. What about the data? So do we have data for VIDES? Yes, we do. Doug Beal's NP pilot study had 35 patients enrolled, and this is all age groups, so from 18 to more than 65 years old. And at 6 months, what he found was that more than 60% improvement was seen in ODI and NRS, and that's whether 1 or 2 levels were treated. 73% of those patients achieved more than 15-point reduction in ODI, as well as more than 50% improvement in pain. And then 60% of those patients had, more than 60% ODI improvement in patients with modic type 2 changes. So I know we discussed modic changes earlier in the night. These are patients that have modic changes in addition to modified Fuhrman scores that are appropriate. Then real world data. So in my practice, we did a retrospective analysis. We had 14 patients, and we analyzed these 14 patients after 6 months of them having VIDES. And the patients ranged from 28 to 78 years old, so all across the spectrum of age. 100% of these patients had more than 50% improvement, with an average of about 75% improvement in pain scores and ODI improvement by 15 points. And we haven't had to treat any of those patients for discogenic pain or axial low back pain since that point. So these findings provided our basis for the current OPP study that we're conducting, as well as RCT that we are going to initiate later this year. So the bottom line is, as you can see, VIDES is just replacing what is lost in the native disc over time. It's doing this without any kind of risk of surgery. This treatment does not rely on a complex biochemical process in an attempt to regenerate disc tissue. It simply restores the function of the disc.
It's a pretty good argument, Noman. Thank you so much. Greg, you have some other thoughts on that? You have 3 minutes to give us the other side of that story.
Thanks, Tim. Thanks, Dawood. That was excellent. And Noman, for me, this is a tough position to come in on the con. You know, I've been a proponent of intradiscal interventions for my entire career. VIDES, PRP, BMAC, juvenile chondrocytes. You know, I hope that all of these succeed, you know, for our patients' interest. I look back at my career, you know, I was asked to be an investigator in the SMART trial early on, as well as a trial looking at intradiscal injections of juvenile chondrocytes. At that time, we thought, you know, that both might be necessary. Whether it's methylene blue or ozone or chemonucleolysis, you know, ablative therapies, regenerative restorative therapies, Mesoblast, Dysgenics, VIDES, you know, we've been searching for the Holy Grail for decades. And, you know, much for like that search, we still haven't found what we're looking for. Back pain is one of the most primary causes of disability, like Noman said, and you know, about 1/3 of all low back pain is related to degenerative disc disease. You know, age-related changes of the disc are common, and you know, these include a number of biochemical and morphologic changes. The microenvironment is acidic and hypoxic. We see poor vascularization, relying on diffusion for nutrient absorption across the end plate. You see pro-inflammatory cascade, while you know, end plate calcification and injury to the cartilaginous surface of the end plate impair the nutrient flow, increasing cell death and nucleus pulposus, and leading to mechanical and chemical pain, as well as neoinnervation. So although these degenerative changes of the disc are frequently observed on imaging, hard to know, you know, who really has pain. You know, most of these people that have degenerative changes, it doesn't cause any symptoms. Because you see a lot of this on imaging, you know, how do we identify the source of back pain? There's no gold standard. You know, discography is controversial. Moreover, you have a presence of a biomarker for end plate pain, you know, clouding the discogenic pain diagnosis. So I ask, is all degenerative disc disease the same? You know, currently there's no consensus guideline for disease classification. It's a much broader diagnosis than what the Fuhrman scale may indicate. Beyond the IDD gradings by Bogduck, and probably more complex than where we are with modic currently. It doesn't account for the complex interplay of the end plate and the disc. It's probably a continuum of sorts where the end plate should be considered more of a discovertebral complex. When we look back at the SMART trial, we talked about BVN earlier, looking at the rule of thirds, you know, 1/3 of those patients had almost 100% pain relief. And another 1/3 got 50 to 75%, the other 1/3 got up to 50%. So with that 100%, there's got to be a pure vertebrogenic pain component. Is there a pure discogenic pain component? You know, we're not sure. So in order to treat the observed changes in the disc, we've got different cellular therapies that are being studied that have the potential to differentiate, promote synthesis, provide structural scaffolding, et cetera.
Nice work, Dr. Moore. Dr. Azim, you have 1 minute rebuttal.
Greg, you make some great points there. Absolutely, I think anterior column axial low back pain is complicated. Just axial low back pain, as you had mentioned, it's kind of the holy grail, figuring out what it is and effectively treat it, and not just treat it, but treat it long term. And my thought process is, when you're looking at patients and you can confirm axial low back pain that may be from anterior column, looking at the biomechanics of anterior column pain versus posterior, and teasing that out on physical exam. If you confirm anterior column pain, you have Doug Beal's data that, again, 35 patients, but out of those 35 patients, we did have patients with modic changes that were there, and those patients still did well. So I would try to look at the least invasive option in my tool belt for a patient if, again, they do have anterior column pain and they have modified Furman scores that are consistent, irrespective of whether they have modic changes or not. And again, I think it'd be a great first step in treatment for a patient that has anterior column pain.
Great,
Dr.
Greg.
Great point, Noman. I would just ask which patients are suitable for the cell therapies and which are optimal. I think we need better techniques to visualize the annulus fibrosis. We did see the post hoc analysis of the VAST trial that earlier transplantation in younger patients, worked better. Is there also some, build on the disease classification? Will these delivered cells survive within the disc? We talk about this hypoxic environment, this acidic environment. How are they going to get the nutrition? So it's difficult to maintain long-term viability. What about the nociceptive nerve fibers, that have come from the neoinnervation? The inability to restore the mechanical loading of the intervertebral disc, biomechanically, it's almost impossible. So, what radiologic improvements are we looking at? The Furman classifications, the high intensity zone. I think it's a misguided focus of cell therapy to solely focus on the nucleus pulposus. And we've got to look at additional strategies for the annulus fibrosis and in-plate repair or combined approaches.
Tim, this is going to be a tough one. I'm going to make you call the winner on this one.
Well, so I'm going to call a winner, but I'm going to ask for something from these two gentlemen. So number one, I think Noman, I think you get the win. You quoted some data. Greg, you quoted the confusion that I have. So Greg, I'm more like-minded to you, and Noman wins. But I think this really, as you know, Aspen, we're trying to always develop new papers to help guide our colleagues, and I think there needs to be a paper reviewing disc pathology. And Aspen review paper, Greg. And so if you guys could lead that, talk about the Furman scale, the modic changes, put it in one paper. It could be a very succinct paper, but I want you guys to consider that and, create an Aspen project. You guys can lead it. We'll have about 20 other authors join you, and we'll have just a summary of what discogenic disease looks like. You guys have any consideration of doing that for us?
That'd be great.
Sounds great.
Okay, let's work on that tomorrow. Give me a call. Very nice.
Right.
Next debate. The winner there was the Tampa Bay Buccaneers, barely. Our last debate of the night is going to be a great debate, I think, and that's a debate of our colleagues. That really, I think we saved you for last. Hopefully, it'll be the best. Dawood, do you want to introduce the debate?
Yeah, absolutely. So, there's been a lot made over the last several years and some kind of I would guess controversial publications out there on different types of burst waveforms. So we're going to talk about the differentiation of burst DR stimulation and are all bursts equal. Dr. Patterson is going to take the pro end of this debate to start.
All right, so what we're going to be really talking about tonight, in my opinion, is we're going to be talking about clustered tonic. Which my understanding is more the tonic signal being cycled. And then the other waveform that we're going to talk about that's also labeled under burst or burst DR is a charge accumulated burst. And I just want to make several distinctions that all bursts aren't the same. And I want to go back to just kind of the history or the evolution of this. So I remember back in 2014, 2015, hearing about this waveform. I was aware that the charge accumulated burst was under an IDE study, had to get FDA approval because this was completely unique and a new waveform that was going to hit the market. But at the same time, I think some of the competitors picked this up, and to their credit, they did an amazing job with marketing. And what I mean by that, they took the tonic signal they tried to cycle it, and then they put it out there as though it was a burst waveform and that they had it to the market first. And so I just want to put that out to the audience and to Soraya that, you know, why would one waveform have to go through an IDE study where another one didn't, because it wasn't unique. It was already something in the market, but it was changing the way the waveform was being applied to the central nervous system. If you break down these waveforms individually, you'll look at the cluster tonic. It's working on the sodium-potassium channels, while the charge accumulated burst is working on the sodium and calcium channels. The cluster tonic has an active recharge, while the charge accumulated burst has a passive recharge. And when you look at the study showing where these affect the CNS, you see that the cluster tonic only works on the lateral pathway, which is what traditional spinal cord stimulation does. But a charge accumulated burst, not only does it work on the lateral pathways, but it also affects the medial pathways of the central nervous system. And then last but not least, I think what also makes the charge accumulated burst signal unique is that the central nervous system holds on to this. There is a carryover effect or retention. And we see on functional MRIs that the anterior cingulate holds on to the signal longer and doesn't let the signal go. So fundamentally, these are two different waveforms completely. And with that, I'll turn it over to Soraya.
Have 3 minutes now to frame your viewpoint.
Hi. Well, I'm going to give you a little bit, and then I'm going to tell you you're wrong as well. So I'm going to give to you that burst DR truly is a unique waveform. None of the other waveforms mimic it. Like you said, it is a packet of activity followed by this passive recharge. And they did the work. Abbott did the work to show that this was safe and efficacious, that it wouldn't burn the tissue and it wouldn't destroy the battery. And you're right, others jumped on board to cycle tonic programs to say, well, we can make this subperception and the same, and it wasn't the same. They were not this true subperception program. It was just cycling of traditional tonic stim. And that, was Boston's, burst 3D, but there has subsequently been an evolution. And now they have truly a subperception platform that is different. It is not the same. It is not the same waveform by any means. And it does utilize a more active recharge, which we talked about. So they are different. What we also know about these subperception programs is that they are likely all activating the dorsal horn rather than the dorsal columns preferentially. We don't know how, and we don't totally know why, but we know they're doing that. So I agree that they are fundamentally different. You can't say that they're the same waveform. They are not. I also, however, think that they are providing activation in similar portions of the spinal cord. What this means, these different waveforms for long-term durability of pain relief, I don't think we have those head-to-head studies of the Abbott burst DR waveform versus, let's say, Boston's microburst program. So yes, fundamentally different. They activate differently, but likely in the same portion of the spinal cord. Where that fundamentally activates differently in the brain, we don't totally know because we haven't done the research yet. I do think that research is coming. I do believe that there is going to be a study that is going to come out in Europe where they are going to look at burst DR and at sort of this microburst platform from Boston. And I think that's going to be very elucidating. So while I do think we can say they're different waveforms, I don't think we can say one is preferentially better than the other when it comes to pain relief felt by patients at this time.
All right, so I got a minute to rebuttal, is that correct? And
That's
by
correct.
the way, sir, I've got a big hug for you and a drink at Nan's coming up next week in Vegas. So the second part I just want to talk about is, talking about how these are also fundamentally different. And you as a neurosurgeon would understand you use neuromonitoring to monitor the spinal cord. And so I just kind of want to talk about Steve Falowski's study and basically in the operating room under neuromonitoring, he applied all waveforms on the spinal cord and saw the results. And what he saw is that with Boston and other burst waveforms or cluster tonic waveforms out there, he saw that you saw the classic tonic. There was a reaction from the spinal cord for every signal that was given. But with the charge accumulated burst, he saw that there was no reaction until the actual signal had stopped. So the 5 waveforms, the accumulation of energy and the recharge. And then he saw that it actually also affected different fibers of the CNS, that it was actually deeper layers of the spinal cord, not just the cover of the spinal cord. So that's the first thing I want to talk about there. Second thing is in medical studies. So if Boston doesn't have the studies, they need to get them out there, because right now Abbott has 8 level 1 studies. 3 of those are placebo controlled or level 1A. And then on top of that, we got physician-driven studies with over 1,000 patients treated over the last decade, showing how superior the charge accumulated burst waveform is compared to traditional tonic stimulation. Now I'll turn it back to you.
So yes, there was differential activation in these patients with the EMG recorded signals. What that means, and of course it's going to be different. It's a completely different stimulus platform, right? It doesn't mean that we are necessarily going to see better pain relief, because we don't totally understand that correlation. Yes, we have great data that Abbott has done that shows that they have really good relief with their platform. And they did compare it to more traditional tonic stim papers to show that their relief was better. But we actually don't have a head-to-head comparison paper where we look at Abbott's Burst DR versus the newer Boston microburst programming. And so I look forward to that paper. It may totally meet out what you are saying here. And I know some of us Abbott people, we have a feeling, a sort of our own clinical acumen of our own patients about which ones we think have done better over the long term. I know a lot of you have implanted many of these platforms and have fundamentally come to find which one they feel works the best for their patients. But I would disagree that we know fundamentally at this point that Abbott's Burst DR offers superior relief to some of our other platforms that we have.
Do I get a rebuttal again?
No, we're done. No more rebuttal. But that was
Well, that was a really strong one. Tim, you want to name the winner, or you want me to take it?
Well, I think we'll both name this one since the last debate, and then we have a few moments to close with a few announcements. So, Russell Wilson, the quarterback, this is a Super Bowl debates. Russell Wilson, I think, Dennis, if I recall, you're a big Denver Bronco fan, right?
Yeah, unfortunately, it's a mess now, isn't it, with Russell?
They really sucked this year, and Russell played terrible. And, I know, Soraya, you're in New York City, and you got the Giants and the Jets, and, good Lord. So you both have had a rough year in football. All your teams are terrible. But, we did have evidence versus there's going to be a paper coming someday. And so with that, Dennis, the Broncos get a win tonight. You get this win, although I love my neurosurgical colleague. You had evidence, and I think you presented a lot of evidence. And so right now, that's the winner. So
okay, I feel a little bit, I limped into this debate like Aaron Rodgers with his Achilles injury right out the gate. So I get it. I support Dennis.
Okay. Elwood?
Well, I think in a way, I agree with you that Dennis made some really strong points, but as a lifelong Kansas Chiefs fan, we could never crown a Denver Bronco fan as a winner of the debate. And I think that just from the scientific perspective, Dr. Motivala probably brought some superior arguments to the table with, really, the bursts are not equal. I'm glad that she acknowledged that, but she also kind of, the most important thing is that we don't know the answer to which one actually, is better from a clinical standpoint. Those studies have not been done. I think, she mentioned that there's a study being done in Europe. So maybe we bring these folks back next year for the same debate for part 2.
All right. Thank you both. We have a few things to finish up. We want to make some announcements. Dawood, you're the announcement man.
Yeah, absolutely. So, it's that time again. We're starting to open up the call for abstracts, and again, for poster abstracts for the 2024 annual meeting. And again, what we're planning to do this year is a couple of unique things. The top 10 or so abstracts will be selected for podium presentations at our annual meeting. Additionally, something cool and unique that we're going to do this year is that the top 10 abstracts will also be published in our peer-reviewed journal, the Journal of Pain Research. We just kind of recently had that arrangement made with our senior editor-in-chief, Michael Schotman. So that's really going to be exciting for those people whose abstracts get selected as the top 10. And there's a QR code that you can use to get to the website to upload your abstracts. The sooner, the better. Next slide. And then, as I mentioned, this is a QR code to register for our annual meeting. Again, as if any of the last 5 meetings were any indication, the hotel will book quickly. So, you know, the earlier you register, the earlier you can get into that room block. Even if you don't, you know, no worries. We've always made accommodations, you know, most likely, as we've done in the past, we've contracted with other hotels outside the Fontainebleau to accommodate people. So, but it's always nicer to be at the Fontainebleau where all the action is happening instead of having to take a cab or walk over next door. So register. You can't register early enough. So there's a QR code for that. And this meeting is going to be bigger and better than before. Next slide. And that might be it. I think that's it. I'll let Tim give some closing thoughts.
It's 9:32 on the East Coast. Thank you all for joining us. I think it was a great debate. I enjoyed all the speakers and I enjoyed the different points of view. And I think we're going to do this again, hopefully next year, if we're all healthy and still around. And we'll hope to see you all in Miami, July 11th through the 14th. Again, you know, it's growing like crazy. I'll see many of you in Las Vegas at NANS, and I look forward to continuing this collaboration together, this mentorship of each other, and really this friendship we all develop as we really go forward trying to help our patients. So Dawood, great job tonight, and we'll see you all soon.
Yeah, thank you so much. And as every Super Bowl, we'll have a recap that we'll publish tomorrow. We'll be publishing the winner of the Super Bowl debate from the industry standpoint based on registration. So look forward for that announcement. Everyone have a good night.
Good night.